Welcome, and thank you for joining us for today's webinar. My name is Vanessa, and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some quick information on the webinar platform. All lines have been muted and on entry and will remain muted for the duration of the webinar. Please submit questions throughout the presentation using the chat and select all panelists. A moderator will ask the comments and/or questions on your behalf at the end of the presentation. If you require technical assistance, please feel free to contact me, the host, via the chat panel, and I'll be happy to assist you. If you need closed captioning, please refer to the link in the chat panel. We also wanted to make you aware that today's webinar is being recorded. And now I'd like to turn it over to Dr. Amanda Acevedo to introduce our speaker.
Hello and welcome to the first webinar in the Achieving Equity in Cancer Pain Management webinar series. In December 2019, the Cognitive, Affective, and Social Processes in Health Research, or CASPR, working group hosted a conference on disparities in cancer pain management. During and following the meeting, it became clear that bridging the divide between basic and applied research in this cross-cutting, transdisciplinary area would require more tangible forums to foster. To that end, Drs. Rebecca Ferrer, Sandra Mitchell, myself, along with extramural members of the CASPR Working Group, Drs. Angela Bryan and Jamie Arndt, proposed a webinar series to continue the conversations that were started during the CASPR meeting. And soon after the meeting, the pandemic and continued instances of police brutality made it clear that this topic is an important, timely, and necessary next step toward reducing inequities in cancer pain management. This first webinar in this series is meant to broadly overview the complex issues in achieving equity in cancer pain management. Each speaker will give a 30-minute presentation, after which they will take a few questions. After all speakers have completed their presentations, there will be a panel discussion. Our speakers today will be Dr. Daryl Gray, Dr. Louis Penner, and Dr. Judith Pace. We are very excited to have these three experts kick off our webinar series. So without further ado, please join me in welcoming Dr. Dale Gray, Associate Professor in the College of Medicine at The Ohio State University, Medical Director of Healthy Communities, and Chair of the Health Equity Steering Committee at OSU's Wexner Medical Center, and Deputy Director of the Center for Cancer Health Equity at OSU's Comprehensive Cancer Center, the James Cancer Hospital. He will give his talk, Multi-Level Approaches to Achieving Equity in Cancer Pain Management at the Intersection of Racism and Health. Dr. Daryl Gray.
Thank you, and good afternoon. Depending on where you are, good morning as well. Thank you, Dr. Acevedo, for that kind introduction. Thank you to the entire team for the platform and for bringing this to the forefront. I sincerely appreciate, Dr. Acevedo, you framing it the way you did, particularly in the context of the events of 2020, now leading into 2021. For all, my hope today is that you gain some perspective that then you can have a lens in which you approach your basic and applied research and maybe ask some new questions or approach community engagement in a different way, or think about how your clinical work as a clinical investigator or clinician can be impacted by what I or the other two speakers highlight today. So just to level set, I want to ensure that we are coming at this from a very similar lens. I just want to take a minute to review a term with you, and that term is health equity. And there is no uniform definition of health equity. I tend to adopt one that was framed by the Robert Wood Johnson Foundation, similar to one by the World Health Organization, in which it describes a time when everyone has a fair and just opportunity to be as healthy as possible, to attain the highest level of health possible. And certainly as we think about where we currently stand, reality, if you will, as pictured by the rightmost image, you can appreciate that there are many who are not at the same level as far as whether we think about resources, resource allocation and access, where we think about health as compared to others. And certainly if we contrast equity to equality, certainly we recognize that if we give everyone the same resources and hope they have the same outcome, that will not be the case. Our goal truly should be towards equity as depicted in the middle picture. Now, again, I am extremely appreciative that Dr. Acevedo framed this webinar series the way she did, really not only describing the what's happened in 2020, but laying the context of events of COVID-19, police brutality. And sometimes what can be lost in these discussions is that this is a race thing that contributes to healthcare disparities. But what I hope to submit to you today for your consideration is that racism is a root cause. Race is a social construct, but that also gives a lens into the social conditions and social factors that play a role into then the health and healthcare disparities. Look for me for a second and revisit in your mind when we started 2020, and certainly the narrative that was emerging in February, March was that, yes, there was a disproportionate burden about COVID-19, but that disproportionate burden was amongst racial and ethnic minorities, particularly as we look at Black and Indigenous people of color. Now, certainly what emerged was, well, these are the same populations that are heavily burdened by cancer. And so as we think about what are the symptoms, and I would describe these downstream health outcomes, cancer included, as a symptom of a larger problem. And so as we go further upstream, many of my public health practitioners will appreciate the narrative of the stream. But if we work further upstream, we see that there are other determinants that contribute to these downstream health outcomes. And in subsequent slides, I'll dig into several examples of these to give you more concrete about how this ties ultimately to biology. But if we think about, if we take the context of cancer, or take the context of COVID-19, we understand that, for example, exposure to toxins can lead to such downstream health outcomes. And if we look at, for example, exposure across population-based health studies, that racial and ethnic minorities, people of color, are more likely to live in areas with higher pollution than those who are not. If we think about issues like food insecurity or access to fresh fruits and vegetables, which, by the way, fruits and vegetables and high fiber and diet is a risk factor for cancer. If we look at access to high quality care, or not even just access, referral patterns to high quality care, we also see there's significant disparity against Black and Indigenous people of color. And so as we think about why these things may be, why there might be income inequality in some communities as opposed to others, why some populations may be, and what framing is around unsafe and overcrowded housing among some populations, we further have to look further upstream. And what we see that the preeminent social determinants of health include racism. So again, it's not necessarily race, but it's discrimination and stressors over time that lead to the downstream health outcomes that, yes, influence things like cancer, and ultimately, to the content of this discussion, can influence cancer pain management. Take, for example, this study. So this study, published in Cancer in 2019, looked at the impact of housing discrimination, racial-based housing discrimination, on cancer mortality. And so to take a step back, if you recall in our prior image, we talked about different social determinants of health that influenced downstream health outcomes. One thing that I didn't mention in that is also as we think about political determinants of health. So we think about political determinants of health. There was an interesting book that I highly recommend you read called Political Determinants of Health by Daniel Dawes, published in 2020. And it really highlights the impact that policies and laws have made over time and how that has manifested, particularly on the health of population, whether it be cancer or otherwise. And so take, for example, this study, which explored Black-white cancer mortality and also explored overlapping that with racial bias in mortgage lending. And what you can appreciate if you look at the figures A, B, and ultimately C as well, what you can appreciate is that in the same areas where the Black-white cancer mortality was highest, we see also higher racial bias in mortgage lending and housing discrimination. Now, how do these things potentially tie together? Well, if you think about the history of something called redlining, which is some population, particularly Black and Indigenous people of color, were not allowed to have mortgages, not giving credit, and really segregated to certain areas in the community. I think about where I was born and raised in Baltimore, Maryland. If you look at where redlining occurred in Baltimore, Maryland, then you overlap that with the life expectancy in those areas, you see a stark difference between the areas that were redlined and the life expectancy there as compared to those other areas that were not. Well, let's take a different view of that. So as we think about the influence of racism, right, and structures, we think about racism in different contexts, both personal, person to person, interpersonal, institutional, and structural. And I think it's really important for us to try to get our terminology on level set so that we understand the potential implications of each. And in my subsequent slides, you'll see this come out in sometimes interchangeable ways, such as institutional and structural, are oftentimes in the literature, particularly social sciences, used interchangeably. But we think about also the overlap of personal and interpersonal. And some of the themes that can emerge, even if it's explicit or implicit, we think about things like implicit bias and how that impacts decision-making, whether at the bedside of a patient, whether that be in our research lab, whether it be on the work that we do in translation. And implicit bias, for those who aren't familiar, those are unconscious associations, learned behaviors over time that can influence your decision-making. And so we see that, again, framing as Dr. Acevedo did in the beginning, whether that be in our policing, whether that be in our healthcare, whether that be in our research. There are different factors, whether explicit or implicit, that impact not only our decision-making, but the health of those whom we serve or hope to serve through our work. Now, again, as I mentioned, it's racism, not race, that drives health inequities. And this is where I want to start to drive in how racism can influence biology. And so in the literature, there are concepts of, and my citations didn't pop up there yet, concepts of weathering and allostatic load, particularly as we look up studies of allostatic load and weathering. And again, allostatic load refers to changes over time from chronic stressors, such as discrimination, such as racism. And weathering is, in like fashion, describes changes particularly to the body, physiology, over time from chronic stressors. And these influence tangible factors such as stress hormones. We think about norepinephrine, cortisol. We think about things like telomere length, which, by the way, telomere length has been associated with risk for development of cancer. So I want you to start thinking about how these structural influences, such as discrimination, such as racism, actually influences downstream biology, particularly as we think about these populations, such as Black and Indigenous people of color, who have experienced chronic stressors over time. In this context, I want to demonstrate and show you a study that was published in American Journal of Public Health in 2006. And they looked at allostatic load, 10 factors of allostatic load. And the probability of having allostatic load is predicted by race and gender, and then looking at poverty and income ratio. What you can appreciate in figure A in the top left is that the probability of having an allostatic load of greater than or equal to 4 was higher amongst those who were Black as compared to whites. If you look at panel B, so the bottom left, you can appreciate that this persisted when we think about Black men and women as compared to white men and women. And then when we adjusted and examined poverty income ratio, what you can appreciate, particularly as we look at the top right and the bottom right panels, is that even after adjusting for poverty, the allostatic load was highest amongst Blacks. And again, allostatic load also being a surrogate for chronic stress, inflammation, and changes to things such as telomere length and biology over time. Now, how does racism manifest across the pain management and cancer care continuum? Certainly, as we look at robust literature, we've seen that pain is more likely to be underestimated and undertreated, particularly amongst Blacks. The literature is most robust when doing Black-white comparisons. So let's take, for example, one study. Now, I won't go into the details of the study. I understand that in a future webinar, this will be explored a little bit more. There was a study that explored the belief systems amongst even medical trainees, including medical students and residents, to see what the difference is in belief systems that could impact health of the population. And I want to pull one piece of this study forward, in that 50% of the medical trainees, 50% of the study population, carried at least one false belief about a biological difference between Blacks and whites. One that was particularly striking was the false belief that Blacks' nerve endings are less sensitive than whites. Again, this was a sample of our future healthcare providers. The other piece is that we've noticed that there are differences observed in pain and cancer diagnosis and treatment recommendations between racial and ethnic minorities. So a difference between what we know to be true, what we know to be standard of care, and what we actually do about it. There was a very interesting recent study out of University of Chicago. Dr. Sonia Kupfer was a senior author, in which they explored genetic testing and then referral for genetic counseling amongst those diagnosed with colorectal cancer. And what they appreciated was that amongst the sample, when they compared racial and ethnic minorities to whites, it was significantly less likely that those who were diagnosed with cancer and even had genetic testing were actually referred to genetic counseling in regards to their diagnosis. Significant differences. And when they looked at those who actually were referred, who were racial and ethnic minorities, they were actually more likely to show up if referred than other populations. And so it's not that people are resisting the recommendations, is that they're not receiving the recommendations or the referrals, for example. I think about data that came out of Texas as well, thinking about work done by Dr. Simpson and Dr. Samir Gupta, in which they looked at advanced colorectal cancer, metastatic colorectal cancer, and the likelihood of being referred to oncology, referred to specialty care, referred for treatment in advanced cancer. And what they found was Blacks were significantly less likely to be referred for, again, standard of care as compared to whites. So we see significant difference in pain and cancer diagnosis and management recommendations. And again, this likely, albeit it's not clear from these studies, can be a reflection of implicit bias and also a reflection of the system that allowed that to happen. But also, we see differences in resource allocation. I think about a recent example that was published in the New England Journal of Medicine of a patient in Chicago who was diagnosed with breast cancer. She went to a community hospital initially and had a mastectomy that was ultimately found to not be indicated. And then was, by happenstance, through a city effort, paired up with a patient navigator who then transferred this patient to an academic medical center where she saw a surgical oncologist as opposed to a general surgeon that ultimately had initially recommended the mastectomy, and then was plugged into getting the care that she needed. I think about more compelling data that has demonstrated the distance between national comprehensive cancer centers, and particularly the distance as compared between Black communities and those of whites. I think about early data from Dr. Harold P. Freeman, who is the pioneer for patient navigation, and what he observed in his breast cancer clinic and the disparities in resource allocation and resources, such as oncologists and surgeons, and the referral patterns. I think about data that came from Dr. Kim Rhodes in California, and how she explored referral patterns, and particularly distance from accredited programs for management of colorectal cancer. And I also think about data that came from Dr. Rhodes that demonstrated that even for patients who live in close proximity to a high quality center, they are less likely to go because they are less likely to receive referrals to the high quality center and more likely to receive a referral to a low volume, low quality center to receive surgery for cancer, such as lung cancer resection and such as colorectal cancer. So how do we begin to dismantle these processes? How do we begin to dismantle racism with the hope of advancing health equity and moving us forward as an enterprise as we think about the work that we do from basic to translational to clinical, the work that we do for applied science, the work we do around community-based participatory research, what are some things that we can do to help move us forward? Number one, I think we can take a critical lens to ourselves and our institutions. What are the policies and practices that are fostered within our institution that promote racism or that are not anti-racist in our ideology? And what are the funding streams that help to support that work and help to sustain these efforts? Do we need, as a global enterprise, do we need more implicit bias training? I would say we do, particularly as we think about our practices around whether it be hiring and search committees, or whether it be even, are there things that we have in our clinical or basic science research protocols that limit the amount or limit the diverse population that is able to engage in that work? Certainly, we need to transform medical and public health education. I gave you one example of trainees who held false beliefs about biological differences between Blacks and whites. I also painted a picture around social determinants of health, and certainly if we're going to move forward as a community of scientists, as a community of healthcare practitioners, as a community of navigators, community health workers, we certainly need to bolster our education around the implications of social determinants of health and racism on health outcomes. And certainly, this is a growing area. And I only gave you a sample of the data, particularly as it pertains to weathering and allostatic load. But we must continue to bolster our support for this research, particularly as those of you who are journal editors, journal reviewers. And we also have to think about the rigor of this work. A lot of the work that has been published recently, at least what we think about what's happened in 2020, since there's been a growth in this literature base around the implications of racism on health. We have to improve the rigor as well. Many are editorials, but we have to go back to tying it to biology as well, such as the work that I highlighted from Dr. Geronimus in regards to weathering and allostatic load. If we are going to move forward, and I highlighted in one of the slides that I showed earlier, the impact of policies such as mortgage discrimination or housing discrimination on health, we have to ensure whether we're looking at policies within our institution or outside of our institution, within our communities or within our healthcare workspace, we have to try to ensure that there is equity in all policies. And so that's why I wanted to give you that illustration initially about what health equity is. And certainly, if we are going to make a difference in the communities that are most disenfranchised, we have to be very proximal to them. We have to amplify the voices of the disenfranchised, and community engaged and community-based participatory research allows us to do so. Well, for those of you who aren't familiar, community-based participatory research involves co-designing the work with the community in mind and with the community. So from the point of the design of the research through the implementation and through then the dissemination of the science, the community is involved. And I strongly believe that it is those who experience and have the lived experience and are most proximal to the disparities, most proximal to being underserved, most proximal to being disenfranchised, that can help us to come up with our greatest solutions to this problem. And last but not least, it's extremely important that we invest in diversity and inclusion. We're at a crisis point right now where the image or the face of our healthcare institution, the face of science, does not reflect the face of America. And if we're going to make a dent, if we're going to make progress in dismantling racism, if we're going to make progress in eliminating health disparities and moving us closer towards health equity, we have to become more diverse in our workforce, scientists and clinicians, patient navigators, community health workers. And we also have to think about what implications this carries for our NIH funding mechanisms as we think about those scientists. I think about a recent Cell article that talked about differences in funding between Black investigators and those who are not. And then also prior research that demonstrates funding differences depending on the type of research, particularly those who are engaged in community-based participatory research or disparities research as compared to those who are not. So we must advance diversity and inclusion if we're going to dismantle racism. And with that, I'd like to just acknowledge those many members of my team, and this is just a sample, that help to advance the work. And I hope you can appreciate the diversity and the inclusion in this environment. I'd like to give a special thank you to Dr. Electra Pasquette, who's been a mentor in this space, and particularly thinking about the implications on cancer health disparities. And with that, I'll stop, and I welcome you to reach out with any questions or concerns.
Thank you so much, Dr. Gray. This is Dr. Sandra Mitchell from the Outcomes Research Branch, and we just thank you for an absolutely terrific overview of that. I think we do have time for a couple of questions, and just looking at questions that are coming in from the chat. I think
I would like to acknowledge. I would like to acknowledge also. I did see something come in the chat that I do think is extremely important. And again, I also acknowledge that you mentioned this was an overview. So certainly, as we think about the impact of the health disparities and how we alleviate health disparities, there are many populations that deserve greater focus. Certainly, I saw in the chat that there is mention of people with disabilities, and that deserves greater attention. There are other subpopulations. We think about sexual and gender minorities. We think about religious groups. I chose to focus on racism according with the request, but I agree that deserves greater focus.
Thank you for that. That was maybe just add to and build on what your comment was, is that this is the first in a series of webinars with the overarching goal of examining strategies to achieve equity in cancer pain management. And as you point out, there are a number of underrepresented and underserved populations where we're going to really try to highlight some of their needs. And those populations haven't had enough focus to date, and the webinar series will attempt to reflect a broad range of those populations. So this is just the first in a series, more to come. And when we close out, we'll say a little bit more about what we're planning for the next series, but we really do appreciate the comment about other populations. There's also a question coming in from the chat, and maybe just try to take this one. Can you say a little bit about the measures, including biologic measures and self-report measures that reflect allostatic load and reflect the concept of weathering? So how do we measure those both biologically and through self-report?
Thank you for that question. So there's, I've seen up to 16 measures for allostatic load. In the study I quoted, there were multiple measures. There were actually two categories of measures. The first category is primary mediators. So it comprised substances the body releases in response to stress. So those include things like norepinephrine, epinephrine, cortisol, DHEA. The second category comprised effects that result from the actions of primary mediators. So examples would include things like systolic and diastolic blood pressure, cholesterol levels, glycolated hemoglobin or hemoglobin A1C, or waist to hip ratio. So I hope that gives some greater lens into the metrics.
Hey, thank you so much. And I think we'll stop there with questions, but realize we're going to be circling back to a really exciting, and we want to leave good time for this panel presentation where all of our speakers can have some cross-pollinating discussions about these questions and topics. So I'll turn it back to Dr. Acevedo to introduce our next speaker.
Thank you. Our next speaker will be Dr. Louis Penner, Professor Emeritus in the Department of Oncology at Wayne State University. Dr. Penner will give his talk on the impact of race-related attitudes on patient-oncologist interactions and cancer treatment. Dr. Penner?
Oh, Dr. Penner, I think we're having some issues with audio. So let's try to see if you are unmuted. So let's try to see if you're connected to computer audio. I think we had you there for a second. If you could do what you just did to reconnect, I think we should be good. Oh, I think we lost him here momentarily. Oh, Dr. Penner, we do see you, but I think the audio is still, we had you for a few seconds just there. Let's see. To our moderators, what we can do is we can move with Dr. Pace, and then we can have Dr. Penner join after, and I can work with him on audio. Oh. Yes, we do, but there is some feedback. Not sure. All right. No, we can't hear you just yet. So I can work with you offline, Dr. Penner. And to our moderators, is it okay if we move with Dr. Pace?
Yes, please. Thank you.
Wonderful.
Yes, potential issue. It looks like Dr. Penner is logged in twice, so maybe that might be contributing to the audio issues.
Yes, I will work with him offline. So Dr. Pace, you do have presentation controls.
So Dr. Judith Pace, the director of the Cancer Pain Program in the Division of Hematology Oncology and research professor of medicine in the Feinberg School of Medicine at Northwestern University, will give her talk on guidelines for the management of cancer pain, achieving equity. Dr. Pace?
Good morning. Thanks everyone for attending this webinar, and many thanks to our conveners for inviting me to be able to meet Drs. Gray and Dr. Penner has been really a wonderful experience. So I have a slightly different direction that I'm going to be taking with this presentation, and that is to address some of the cancer pain guidelines that exist and to compare and contrast these different guidelines to look at some of the strategies endorsed by these guidelines that might support access to equitable care, and then to summarize opportunities for the future. What comes to mind when I think of equity in relationship to cancer pain is a very old study by a good colleague of mine, Sean Morrison, who's at Mount Sinai in New York. This study is 21 years old now, and it reflected what I was seeing in my practice in Chicago. Sean put together this very pragmatic study in which 30% of the New York City pharmacies were queried. And it was a random sample. The pharmacists responded, so they had a fairly good response rate of 81%. And it is not surprising to those of you who are clinicians or who were clinicians at that time that 51% of those pharmacies did not have an adequate supply of opioids to treat severe pain. And of those pharmacies, only 25% in non-white neighborhoods had a supply versus 72% in predominantly white neighborhoods. And they really did a nice job of qualifying for other kinds of crime and other kinds of issues that might have altered supplies within different pharmacies. This really just demonstrates what many of us see in our clinical practices, even though it was written 21 years ago. So we see a paper that was invited, a colleague of mine and I were invited to provide this information for the Journal of Clinical Oncology. We were asked to talk about the over and under treatment of pain in people with cancer. Well, talking about under treatment was pretty easy. There are many papers demonstrating the barriers to adequate pain control in people with cancer. However, we were starting to see the implications of the opioid epidemic, and the suggestion that some cancer patients might be overtreated really rubbed many of us in a very uncomfortable way. So when we looked at the literature, the undertreatment, as you would expect, our older population of patients for a variety of reasons, for those with a minority status, women, and those who had a good performance status. There was just this disconnect between clinicians and the patients. Well, you're looking pretty good, so maybe opioids or treatment isn't exactly what you need right now. And when we looked at the limited data at this time of variables that were related to overtreatment, we saw one in particular, and that was access. Limited access to physical therapies, mental health counseling, integrative approaches, and all of the holistic, multidisciplinary treatments that might allow people to obtain good cancer pain control with less, or maybe in some cases without opioids. So we began to see that we needed to look more closely at the factors that were involved. And the American Cancer Society came through with an excellent survey. This was the American Cancer Society study of cancer survivors published in 2016. And they documented these socio-demographic inequalities in barriers to cancer pain management, and further informed the fact that minority cancer survivors had greater odds of reporting that the medication or the treatments that were prescribed were too expensive, that their health insurance did not pay for these treatments or did not pay adequately for these treatments, that the pharmacies in their neighborhoods did not carry the medications. So here we are, 16 years after Sean's paper, the problem persists. And the difficulty in finding a pain expert was another significant barrier for our minority patients. Now, at the time that we were beginning to see these challenges and these barriers and to document them and systematically evaluate, we had another major crisis that was evolving, and that was the opioid misuse epidemic, where we were seeing a rising number of deaths. Initially, this was from prescription opioids. Over time, the problem has become illicit heroin and illicit fentanyl. But we were struggling in the mid-2015, 2016, and throughout that decade with trying to achieve balance. How do we provide good cancer pain control with this other public health crisis? In 2016, the CDC came out with guidelines for prescribing opioids for chronic pain. These guidelines were intended for a primary care setting, and they were also intended for chronic use of opioids, and they defined that as use for 3 months or longer. Initially, they excluded people in hospice. During the public comment section, many of us protested that that was too narrow. And later, the exclusion criteria included people receiving active cancer treatment, people in palliative care, and people at end-of-life care. Now, there was much controversy about the process related to the guidelines, or much discord, I should say. One of them was that it was open for public comment for a very short period of time, and the CDC did respond to that concern by reopening public comment. There was concern about who was sitting on the panel, etc. But in actuality, most of the guidelines, most of the recommendations within this guideline, we could all agree on. They were about safe prescribing, about using all of the tools in our toolbox, non-opioids, adjuvant analgesics, the other interventional therapies, physical therapies, cognitive therapies, etc., to the greatest degree possible. And in fact, the intended goal of the CDC guidelines is stated here by Dr. Dahl and her colleagues. Improving the way opioids are prescribed through clinical practice guidelines can ensure that patients have access to safer, more effective chronic pain treatment while reducing the number of people who misuse, abuse, or overdose from these drugs. Now, the problem related to the CDC guidelines were several recommendations that many of us, some of us sitting on other federal committees, protested. And that was a ceiling of doses, a recommendation that people in general should not get more than 50 milligrams of oral morphine equivalents, and that 90 milligrams was rarely warranted. And the other was that people should receive a 3-day supply of medications, and in some cases, that might be 7 days. So these guidelines were released with quite a bit of fanfare. And as I said, they were well intended, and most of the recommendations were in agreement. Most of the pain experts at that time were in agreement with many of the recommendations advanced by this guideline. But let me share with you just one of my many patients who suffered the unintended consequences of these guidelines. This was a gentleman who was in his early 70s, an African-American man with metastatic prostate cancer. And again, you can see that big red arrow, but you do not need to be a radiation oncologist to see that this person has an impending cord compression from significant disease within the spine at T11. So when he received his radiotherapy, he was admitted to the hospital, high course of corticosteroids, the usual treatments. And then when he was discharged home, he and his family had to drive to multiple pharmacies to be able to find the medications. Once they did find a pharmacy that carried the medications, insurance would not pay initially. They required a prior authorization. And that led to several days in delay. For those of you who aren't familiar with prior authorization, most require 2 to 3 business days to provide this provision. And if you ask for an urgent review, you might get it in 24 hours. The reason he received this warning about prior authorization was that the dose exceeded the CDC guidelines. So even though this gentleman was in active treatment, the guidelines were applied to him, and this was our fear. And also the supply exceeded the 7 days. We found that this gentleman, once he was able to get the medication, was taking less than what we had prescribed. And when we asked him about that, he said he felt terrible, that the way he had felt at the pharmacy and from trying to fill these medicines, that there must be something wrong, that people must think that he must be addicted because of all of these obstacles. And in fact, he was also fearful that when it came time for a refill, he would face these same kind of obstacles and run out of the medicine. So he was not taking it as it had been ordered. The American Society of Clinical Oncology recognized these barriers and surveyed oncology practices. First in 2016, they had issued a policy statement about the need to balance public health concerns about the opioid epidemic with the access to opioids that cancer patients absolutely need. And in the lower right-hand corner, you can see as they resurveyed these practices in 2018, over a 2-year period, the barriers got worse. That insurance denial was much higher at 30%, that the limited numbers of refills was greater than 2/3 of the time. And in the lower left-hand corner, you can see that 69% of the oncology practices surveyed reported that prior authorization was a barrier, as were limits on pills that were prescribed, caps on maximum dosage, and that patients were often unable to obtain the medications at local pharmacies. 92% of these oncology practices reported being concerned that these restrictions were resulting in undertreatment of cancer pain. Now, there are numerous guidelines in addition to the CDC, which, by the way, was not intended for cancer pain. It was intended for our primary care practices. But that the WHO is an international guideline, as is the European Society of Medical Oncology. The National Comprehensive Cancer Network is the guideline that guides our clinical practice in the United States. And this guideline is extensive, 100 plus pages of documents that's updated several times each year. And all of these documents suggest or demonstrate that opioids are the mainstay of moderate to severe cancer pain management. So despite the fact that we have an opioid epidemic going on, we need to rely upon this class of medications for people who have moderate to severe cancer pain. So ASCO commissioned a panel of experts to be convened to develop a clinical practice guideline to address the special needs of a newer population that we were beginning to see. And this panel worked to develop a systematic review of the existing literature related to cancer pain management in survivors. Now, the first thing we needed to do as a panel was to identify who is a cancer survivor. It may seem self-evident, but frankly, survivor can be defined quite differently. Most patient advocacy groups define it as from the moment of diagnosis through the rest of their lives. And that's very supportive for a person who has received a cancer diagnosis. But for our purposes in trying to develop a guideline that would address the unique challenges of those who had already completed their active treatment, we needed a little bit more narrow definition. And even as you can see from this excellent paper by Deborah Meyer and her colleagues, we see that there is a varied trajectory for cancer survivors. Some are going to live cancer-free for the rest of their lives. Many are going to live for quite a few years, but will experience one or more serious late complications of their treatment. And I have to say, just as an aside, many of my patients in my clinical practice who have been dying from COVID-19 tend to be people in this particular group. They are people who have survived their cancer, but are experiencing complications from treatment. Some people will live for many years, but will die of a late recurrence. And some will live cancer-free, but will develop a second cancer. And I have several patients in my caseload right now who have had 3 different cancer diagnoses, unrelated. And then there are people who are going to live with cancer for the rest of their lives. They'll have intermittent periods of active disease requiring treatment, and they'll live with cancer continuously without a disease-free period. The magnitude of the problem is significant. 16.9 million people in the United States are cancer survivors. 2/3 of those people are living 5 years or longer. And the problem of pain is significant. In several studies, the prevalence is 40% or higher. So guidelines to address pain in this population serve a large group of individuals, both in terms of numbers and in terms of people in need. So our expert panel developed 3 broad categories of recommendations: screening and comprehensive assessment with attention to the different cancer treatment syndromes that exist. We also looked and made recommendations about treatment and care options. And then finally, we outlined risk assessment, mitigation, and universal precautions. Now, many of the pain syndromes experienced by cancer survivors are not related to the cancer. In fact, the majority are related to our treatments. So the beginning part of our document was devoted to outlining what some of those treatments might be, just to give the universe of potential syndromes. And it's evolving. So we have chemotherapy-related pain syndromes, things like long-term complications of corticosteroids, avascular necrosis, chemo-induced neuropathies. We see hormone therapy-related pain syndromes like aromatase inhibitor-induced arthralgias and myalgias, and radiation-related pain syndromes, although my hope is that over time, with the amazing transformation of radiotherapy and the conformal techniques that can be done, we're going to see fewer of these longer-term chronic pain syndromes. Stem cell transplant has certainly led to a significant amount of cures, but also graft versus host disease in those allogeneic patients. And then surgical pain syndromes we've known about for hundreds and hundreds of years. We are just learning now about the chronic pain syndromes associated with immunotherapies, with CAR T, and with any evolving therapies. So an astute clinician needs to be aware of all of these different pain syndromes and also needs to be able to assess whether this is one of these existing syndromes or is this a new cancer or recurrent disease. We also outlined non-pharmacologic interventions and looked at the strength of the evidence because there is great variability. And the truth is, in most, even the most comprehensive cancer centers, all of these different disciplines are not necessarily represented, but those of us who work with people who have cancer-related pain know who our colleagues might be, either within our institutions or in close proximity, where we might develop sort of a matrix system to refer. So physical medicine and rehab offer a wide array of very useful interventions: physical therapy, occupational therapy, etc., orthotics, integrative therapies, massage, acupuncture, music, interventional procedures, nerve blocks, infusions, psychological approaches, cognitive behavioral therapies, distraction, relaxation, guided imagery, and neurostimulatory therapies like spinal cord stimulation, TENS units, and transcranial stimulation. We also outlined the adverse effects associated with long-term opioid use. This was relatively unknown not so long ago, and I can attest to the fact that as a brand new staff nurse, my very first job was on an oncology unit, and I can say it was a very long time ago. We only used opioids in those people who were actively dying. And so we never saw these kinds of side effects. And it wasn't until we felt more comfortable treating people earlier in the course of their illness with opioids that we began to see endocrinopathies like hypogonadism, which can lead to quality of life issues like reduced libido and performance challenges, but also infertility and problems with bone health. We also can see neurotoxicity, sleep-disordered breathing, and other long-term effects that we need to consider as we are evaluating the risks and benefits of long-term opioid use. So in our guideline, we describe the risks and how we might assess them, because we need to do a risk assessment. It isn't just asking about the pain intensity score, and it never was. We obviously do a very thorough pain assessment. We also look at function. That's something a little different than maybe 10 years or so ago. We don't look at an outcome of a pain intensity score now. Now it's about what can you do? What will you be able to do? If we can do a better job with pain control, what might we be able to help you with? So for some people, it might be able to return to work. For others, being able to go to the gym or attend their physical therapy. And for some of my patients, the goal may be to be able to hold their grandchild. And in addition to those assessment considerations, we also need to look at current and past history of substance use. We look at family history, which gives us a proxy for environmental and genetic exposure. And we ask about past history of abuse and PTSD. That gives us a very strong sense of that individual's risk. Now, it's not preordained just because someone has some of these risk factors. There are other mitigating factors, but there are some mitigating factors that we can employ. And these are called universal precautions in some of the literature. And here I want to emphasize the word universal. Now, we use prescription drug monitoring programs. These are excellent tools, and they should not be looked at as a punitive effort. PDMPs, as they're called, can help us identify when did the patient get the medicine filled last? Did they get what we had ordered, or did they get a partial fill? When will insurance allow this medicine to be filled again? Which pharmacy did they employ so we can know which pharmacies carry the medication? So they provide us with a wealth of information that actually assists our care for that patient. Some states have mandatory requirements about checking the PDMPs on a regular basis. Some institutions have implemented these, but clearly they are an extraordinary tool and should be used on a regular basis. Urine toxicology is another piece of this toolkit that can be used on a regular basis to determine, is the medicine that we're prescribing being taken? Are there other medicines that we haven't been prescribing that are being ingested? And so some people choose to use urine toxicology, others choose not to for a variety of reasons. But if this fits into your clinical practice and your clinical setting, you must use it universally, not just for those people that you perceive to be at risk, because we already heard from Dr. Gray about implicit bias, but it needs to be employed for all patients, regardless of age, color, sexual orientation, socioeconomic status. Any kind of mitigating tool that you employ needs to be used across the spectrum of care. Some people believe strongly in written agreements, or formerly called contracts, and some do this more verbally. So again, you need to look at what works best for your clinical practice and employ it for all patients. Then what do you do with all this information that you've just assessed? Well, you assess and stratify the risk of opioid misuse. You decide whether or not it's prudent to prescribe or whether it's indicated. And if it is important to prescribe, then you minimize the risk. How do you do that? You optimize the non-opioid type therapies, whether it be pharmacologic and non-pharmacologic. You make sure that you get treatment for any kind of comorbid mental health challenges, anxiety, depression, sleep disorders. And the truth is that cancer survivors often experience significant anxiety and fear about potential recurrence. We then monitor for the drug-related behaviors, we monitor adherence, and if we do see any kind of aberrant behaviors, we respond to that. And we employ our addiction specialists and our psychiatric consultants to assist. So those were the recommendations of that clinical practice guideline, including weaning, so that for many cancer survivors, it becomes time to reduce the opioid doses and frequency. This can be done very slowly. There aren't very many guidelines about how to do this. The VA and the Department of Defense suggested 10% per week. Because my clinical practice is outpatient, I tend to do this much more gradually. I offer lots of psychosocial support and coaching and lots of enthusiasm for helping patients get through this. We optimize, again, our non-opioid therapies, and we provide a clear plan so people know where we're going. We also describe safe use. That includes safe storage and safe medication practices like locking up the medication, using lock boxes, employing nasal naloxone. I can tell you that 2 years ago or so, insurance companies weren't paying for this, and unfortunately, patients were being charged a significant amount of money, about $150. But now in most states, this is being paid for, and it's mandated. And in fact, in many states, a prescription is not even required. There are also take-back programs so that once individuals no longer need the opioids, they aren't sitting in their home at risk for theft or accidental ingestion by children or others. So our guidelines were released and disseminated, and an interesting and important editorial appeared in JAMA Oncology. The colleagues from the University of Pennsylvania identified that the CDC, the NCCN, and the ASCO guidelines weren't always harmonized, that there was disparity amongst these guidelines, and that might lead to confusion. And so the leadership of NCCN and ASCO put together a panel, a day of meetings in the old days when we actually met in person, not that long ago. And the purpose of this was to bridge the gap, to clearly evaluate the different guidelines to ensure that there wasn't inconsistency. And these were the guidelines that were evaluated. We looked at the CDC guidelines, and Dr. Dowell was represented there that day. The NCCN guidelines for adult cancer pain, and Bob Schwarm is an anesthesiologist from St. Louis, who is the chair of that committee. And full disclosure, I also sit on that panel. The NHLBI guidelines for sickle cell disease were included, as well as the ASCO guidelines. Not only are cancer pain guidelines, but also the NCCN guidelines for survivorship were included. We had a panel that began the day with remarks from Dr. Scott Gottlieb, who was at the time the FDA commissioner. And after a full day of fully evaluating these different guidelines, we came to the conclusion that actually each guideline varies with the intended population, with the target audience, with the methodology employed, and that really there was no disagreement if the guideline was applied to the appropriate patient population and the appropriate clinical setting. And you can see some of the common themes here about using multimodal therapy, about assessing risk for misuse, how we might employ safe practices. So to conclude, you might be wondering, we've talked a lot about guidelines. How can these guidelines advance equity in cancer pain management? Well, they promote evidence-based practice. And sadly, we have many, many gaps in our science. Many of the medicines we use for cancer pain control are very, very older type agents and lack much of an evidence base. So we need to not only use the evidence that we have, but to promote the generation of additional research. And we do that by looking at the gaps. Where are our gaps in research? And what about the gaps in policies, the gaps in regulations that all lead to the barriers that I described? We need to fully identify the barriers. And as Dr. Gray mentioned, in developing research, we need to employ and engage our patient populations. This is really important that we determine what barriers our patients experience, because of course I learn from my patients where those barriers lie, but they're often concerned about sharing even some of the greatest details about some of the slights that they reveal, that they experience from maybe some of us in our clinical settings, some of the pharmacies, from other family members, from the public. We need to fully understand what these barriers might be. And all of us, as Dr. Gray endorsed, we need to recognize our own implicit bias. I just fielded a question from a patient this morning who experienced obstacles at his local retail pharmacy in obtaining his opioid for severe pain. And he said, "Judy, do you think I should wear a suit next time I go to the pharmacy? Do you think maybe they'll give me my medicines then?" We need to educate clinicians, patients, families, payers, and legislators. We need to continue to advocate for access to care. And so I thank the NCI for putting together this webinar today, because this is one step of many that will help make us aware of where these gaps lie, and then develop partnerships. Yes, I've identified some of the barriers. We need to reach across the aisle, if you will, to talk with these other components, other groups, other populations, other businesses who work with us to provide the care that our patients need, to ensure that this is seamless for our patients. And don't give up. I always end my presentations with this quote from Margaret Mead: "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." Thank you so much for listening to me this morning.
Thank you so much, Dr. Pace, for just an outstanding presentation. And there's just, as this is the launch webinar, you've really also provided a really extensive tent around a lot of those structural aspects that impede access to effective pain management, and have kind of begun to foreshadow some of the topics that we will be trying to address in subsequent webinars. I want to have us move on to Dr. Penner in just a moment, but there is one question, and we'll circle to the other questions in the panel presentation, but one question for you that has come in from the audience, just about any ideas how to get insurance coverage for alternative and complementary therapies, things like PT and massage. A lot of times medications will be covered, but some of these complementary therapies will have caps or will not be covered at all. So do you have any thoughts about that from a policy or a clinical perspective?
There are many, many efforts being directed at precisely that problem. And I see that the NIH has been working on that, the different pain working groups. There is the HEAL initiative that is being supported by or led by Rebecca Baker and others, to shine a light on the problems of pain management, inadequate pain management, and the problem of substance misuse. And in fact, by supporting the reimbursement of some of these non-pharmacologic therapies may actually lead to reduction in the use of pharmacologic therapies. So yes, it's a work in progress.
Great. Well, thank you so much. And we may circle back to some of that too during our panel presentation. So I'd like to turn it back to Dr. Acevedo to introduce our final speaker. And then right after Dr. Penner, we'll move into the panel presentation, which is going to be very rich with these three exciting speakers.
Thank you. Last but not least, Dr. Louis Penner, Professor Emeritus in the Department of Oncology at Wayne State University, will give his talk on the impact of race-related attitudes on patient-oncologist interactions and cancer treatment. Dr. Penner?
I'm presuming now people can hear me. Is that correct? Okay, great. Next slide, please. We begin with, before I begin, I want to make a couple comments. I really appreciate both previous speakers. I really appreciate Dr. Gray's comments, because what I'm going to talk about today, you have to put in the context of the great social problem of racism and racial discrimination. And while I'm going to be talking mostly about the effect of racism it's going to be at the level of what I refer to is individual racism, but that has to be placed in the broader context of the enormous social problem that America's had before it became a country of racism. So with that, we begin with the simple fact and discouraging fact that Black patients are substantially more likely to die from their cancer, excuse me, compared to white patients. Next slide, please. In terms of what we're going to cover today, we're going to cover racial disparities in cancer mortality and treatment. We're going to talk about communication and racially discordant medical interactions and the role of both physician and patient race-related attitudes. And then I'm going to talk some about racial disparities in pain management and the role of race-related attitudes. Next slide, please. The first slide I want to present presents something called odds ratios. If you're not familiar with odds ratios, all they're really describing is the relative probability that something will happen when you compare two groups. So if you look on the incidence side on the left side, what you see is that the incidence of breast cancer is marginally higher for Black women than it is for white women. But then if you look on the right side, you find that the difference in mortality, the odds that a Black woman will die of breast cancer are much higher. And that is, even when you control for incidence rates, you still find that Black women are much more likely to die of breast cancer than are white women. Next slide, please. Now, the most important thing about these kind of data, and obviously this is true across almost all cancers. The troubling thing is that the greatest mortality disparities are for the most treatable cancers. Next slide, please. I want to go over very briefly some examples of treatment disparities. This first one was a study done by a colleague and friend at the University of Michigan, Jennifer Griggs, who was a medical oncologist who specialized in breast cancer. And this is the relative odds that a woman diagnosed with breast cancer that's going to be getting either neoadjuvant or adjuvant chemotherapy. The relative odds that a Black woman versus a white woman is going to be substantially underdosed in chemotherapy. And in fact, Black women are about almost 3.5 times to be underdosed to the level where the chemotherapy, chemotherapy they're receiving is really non-effective. It's essentially equal to no chemotherapy. Next slide, please. This is another slide showing yet another racial disparity. Black patients with leukemia are significantly less likely than white patients with the same disease to receive chemotherapy, and that difference is significantly related to survival. Next slide, please. We also find that Black prostate cancer patients are less likely to get a cancer pelvic lymph node dissection. Essentially what that is post-surgery is you look at lymph nodes to find out if in fact you have caught all the cancer or whether the cancer is spread beyond the primary site. Black patients are significantly less likely to get that very critical aspect of surgery for prostate cancer. Next slide, please. And the next slide shows the same thing. This is the relative odds of receiving surgery for esophageal cancer. Again, you see across the 3 stages that Black patients are invariably less likely to get surgery for their treatment. And again, this surgery is related to survival rates. Next slide, please. And I believe finally, Black surgeons with patients with head and neck cancers are less likely to get surgery. And again, this is related to the outcome, that is to survival. Next slide, please. I'm sorry, this final one relates to pain. There's a more subtle difference. These are cancer patients with chronic kidney disease and were receiving analgesics for their pain. They're receiving either morphine or oxycodone. This study, by the way, if you look at the date, was done substantially before there were changes in the guideline about giving patients oxycodone. But that's not the important thing. What is the important thing about this slide is that the morphine has metabolites in it which are very, very dangerous to the health of the patient. And if you look at the difference, Black patients were much more likely to get morphine relative to white patients. They're much less likely to get oxycodone. And then you see the consequence of this is they're much likely to have had adverse effects from the analgesic than white patients were. So in a subtler way, it's not simply that the Black patients were being underdosed, which some of the previous speakers have talked about, it's they're getting a different kind of medication. Next slide. So what are the causes of these treatment disparities? This was addressed in an important volume, I assume many of you are familiar with, Unequal Treatment, which was published by then Institute of Medicine. And it pointed to a number of different causes of treatment disparities, but the ones we'll focus on today are patient-provider communication and patient and provider attitudes. Next slide, please. Sorry. So what we'll be talking about today is racially discordant oncology interactions. Why is it important to study these? First of all, Black people constitute a significant segment of cancer patients. With regard to males, the incident rates are much higher than for whites. Yet very few Black medical oncologists in the United States, probably 2.3%, it may even be less. There are very few Black medical oncologists in the United States, maybe 2.3%. And thus, we estimate about 80% of Black patients' medical interactions are likely to be racially discordant. This is from an article that was done by one of my colleagues, Lauren Hamill, at Karmanos Cancer Institute. Next slide, please. So when we look at clinical communication between non-Black physicians and Black patients, we find that on the part of the physicians, there's less information provided, they're less patient-centered, they're more verbally dominant, and they're more contentious. On the part of the patients, that is patients of color, they ask fewer questions, they have less participation in the decision-making, and they have less understanding of the diagnosis and the treatment plan. So what we find is that communication is much poorer when we're talking about a racially discordant medical interaction. Next slide, please. Now, I want to digress, and in some ways this repeats what Dr. Gray said with a few slight variations. There are three types of anti-Black racism. One is structural racism, which is essentially the legalization of inequitable practices that disadvantage Black people. For example, legally segregating Black people into neighborhoods with medically under-resourced area. And Dr. Gray touched on this when he talked about redlining in Baltimore. The second is institutional racism, which is in some ways a much more serious problem, because this is long-standing practices that intentionally or unintentionally disadvantage Black people. A recent example of this is including race in the diagnostic formula for kidney function without a scientific basis. The effect of that is that if you get a kidney test and you get your results of it, it turns out that the same result indicates a much better functioning kidney if you are identified as Black or African American than if you're identified as white. But this article by Valles et al. In the New England Journal of Medicine that came out last year points out there's basically no scientific basis for this. It's just the way it's always been done. Finally, there's individual racism. This is differential and less favorable treatment of Black people in interpersonal interaction. That's primarily what I'm going to be focused on today. For example, dismissing Black patients' reports of symptoms. Next slide, please. Now, at the level of individual racism, there are two related types of race-related attitudes. The first is conscious feelings about a racial group shaped by past and current race relations in the U.S. And these are known as explicit attitudes, and they are known to the person who holds them. Their expression is controllable, and they're the product of conscious reasoning, and they're logical to the holder. Now, one place where I would disagree slightly with the previous speakers is let's not forget about explicit attitudes. The things we've seen in the press that we've heard about are not the product of some automatic implicit bias. They're the product of explicit biases. And we have to recognize that they still exist and they still do harm. But I'm going to focus more on non-conscious thoughts about a racial group shaped by past experiences, or what is known as implicit bias. Now, the major characteristics of implicit bias is it exists with limited personal awareness. Its expression is usually automatic, and its expression is usually less controllable. Next slide, please. Now, what we know about physicians is that they show much higher levels of implicit bias, or they show extremely high levels of implicit bias. What this slide shows you is the extent to which there is preference for whites over blacks. Now, let me make it clear. This is not dislike for blacks. This is preference for whites over blacks. And what we see is that there's a very strong preference at the implicit level and a moderate preference at the explicit level for male MDs, and the same pattern, although less dramatic, for female MDs. So implicit bias is present and quite high among MDs in the United States. Next slide, please. Now, to put this into context of the research myself and my colleagues at Karmanos Cancer Institute have done, we view these interactions, these racially discordant interactions, as having the following components. The first component is race-related attitudes. On the part of the patient, they affect how the patient communicates with the physician and how they perceive what the physician does. On the part of the physician, they also affect communication with the patients and perceptions of the patients, and they affect the physician's own communication and perceptions. And notice that these things are reciprocal. That is how the patients communicate and their perceptions during the interaction affect the physicians, and the physician's communication and perceptions affect the patient. Both of these affect treatment decisions, both short and longer term. So this is the model we use to analyze physician-patient communication. Next slide, please. Now, our research program over the last 15 to 17 years ago has looked at the effect of physician racial bias on communication and racially discordant interactions. In the original study we did in 2010, was not done in a cancer setting, was done in a primary care clinic in an area in a neighborhood in Northwest Detroit. And what we found is that higher physician explicit bias led to the physicians reporting less involvement of the patient in treatment decisions. Higher physician implicit bias was perceived, the physician was perceived by the patients as less warm and friendly. Also, physicians used more anxiety-related words, and they had more verbal dominance in the conversation. Before I move to the next slide, I want to go back to that first finding. They were perceived by patients as less warm and friendly. Let me give you a context for these interactions. These were typically between patients and physicians who did not know one another. As we know, one major aspect of inequities, racial inequities in treatment, is continuity of care. That for Black patients, there's substantially less continuity of care. These were highly structured 15-minute interviews with patients who, most of whom were at the extreme end in terms of lower SES and had a number of problems in addition to the medical problem they're presenting with. So this is a highly structured 15-minute interview with a patient who is stressed on a number of different areas. But yet what we found is that the patients picked up on something. I look at these interactions, and to be candid and honest with you, I can't see anything. I'm also an old white guy. But our patients were picking something up. And what they were picking up is being followed up by colleagues of mine in the population studies program at Carmanos. Next slide, please. Now, not only did patients pick up the main effect of implicit bias, there's also the fact that explicit and implicit bias can interact to affect white people's reaction to Black people. This is known as a person who's an aversive racist. What that means is at an explicit level, the person genuinely finds the idea of being a racist aversive. At the implicit level, though, they hold negative thoughts and feelings about Blacks. Remember, at the implicit level are more or less automatic responses that are largely outside of the realm of awareness. So the profile that describes an aversive racist is low explicit bias or controlled bias and high automatic implicit bias. This is pretty subtle. Next slide, please. Yet what we found in this first study was that the physicians who fit the profile of the aversive racist, that is low explicit bias, high implicit bias, okay? That's the blue bar with the arrow. The patients were significantly less satisfied with them. So the patients were picking up an even more subtle aspect of racial bias. Next slide, please. In a study done by Nao Hagawara, who's at Virginia Commonwealth, who was a postdoc with us, she further explored the effect of aversive racism by looking at the physician's affect. That is, what kind of expressions they were displaying. I should mention that in the work we did on racially discordant interactions, with the permission of both the physician and the patient, we video record them. So we have video records of that. So we have blind judges rating things like observed affect. And what we find here is something very interesting. When the patients don't report any past discrimination, both aversive racists and non-aversive racists pretty much react the same way. But if the patient reported a lot of past discrimination, the aversive racist, again where the arrow points, displayed significantly more negative affect. We believe that these patients were presenting themselves as somewhat more difficult because of the experience they'd had with racial discrimination. And while that doesn't have much impact on the other doctors, it had a significant impact on the doctors we classify as aversive racists. I'm not going to show you the other slide, but we also found for the amount of positive affect they displayed. Next slide, please. Now, we replicated this work in an oncology setting, and we found basically the same results. That is, that higher oncologist implicit bias, again, led to lower patient reports of patient-centeredness, more patient difficulty remembering the conversation, less patient trust of the oncologist, which showed up 1 week later, less supportive physician behaviors as judged by independent judges, and shorter interactions. That is, the interactions between physicians higher in implicit bias were significantly shorter than those with physicians with lower levels of implicit bias. Again, put this into context. These were initial meetings between Black patients and non-Black physicians. These were basically the patients were either finding out that they had breast cancer or that the surgery that they had for breast cancer, despite that, they still needed more treatment. So think of all the factors that are imposing on the minds of these patients. Yet in this critical life or death situations, the patients were still able to pick up on the implicit bias of physicians. Again, suggesting that I don't know a better word for it, there's a radar among Black patients that enables them to see the manifestations of implicit bias in the physician's behavior. Next slide, please. Now, what's the impact of that? Well, higher implicit physician bias leads to less supportive communication, which was observed by blind observers too. That is, people who watch the video. Okay? And that in turn affects the patient confidence in treatment. In other words, higher physician implicit bias indirectly produces less patient confidence in treatment outcome. It also, by the way, we don't have a slide here, but it also predicts more patient anticipation of difficulty in completing the treatment. So we see that it not only affects the behaviors within the interaction, but expectations about treatment. Next slide, please. Now, there's been much less research on the effect of patients. Indeed, even in the original unequal treatment, they tended to dismiss the effect. They gave great emphasis to attitudes and beliefs of healthcare providers, but almost none to those of patients. The implicit assumption in the research literature is that patients are essentially passive recipients in this, and they don't take an active part in the interaction. If there's one other meta message that has come out of research, is this is simply wrong. So what have we found? We found that the more group-based suspicion, that is, belief that medical systems provide less than optimal care or even mistreat members of your own group, results in, this is on the part of the patient, less perceived patient-centeredness, more post-visit distress, less post-visit trust, less confidence in treatment interactions, and work being done presently by my colleague Lauren Hamill. It also results in something called nonverbal synchrony, which is non-conscious coordinated movement over the course of an interaction. So at this very, very subtle level, non-conscious level, we know that group-based suspicion has an effect on communication in these interactions. Also, more personal mistrust of physicians, which is discrete from medical group-based suspicion, results in patients talking more, less physician verbal dominance in the interaction, and less patient use of positive emotions. So here we begin to see that patients are not simply passive recipients, but rather quite active participants in the interactions in these racially discordant medical meetings. Next slide, please. Now, what's the effect of that? Well, the higher patient suspicion of medical care results in something that we frankly didn't expect. And that is the oncologists perceive these patients have lower perceptions of the patient's attributes, personal attributes. For example, their education, their lifestyle, their ability to comprehend what goes on. Now, I digress for a moment. You say, well, maybe these highly suspicious patients are in fact less educated, or in fact do comprehend this less. So we statistically controlled for this, and actually that relationship becomes stronger. Now, what's the consequence of that? Again, we have an interesting indirect effect. Patients who are higher in suspicion of medical care result in the physician believing that the patient is going to be less able to tolerate treatment regimen. Now, we don't know what the long-term consequences of these would be, but it's reasonable to surmise that if the patient is having some of the kind of problems that Dr. Pace was referring to later, this may affect the treatment decisions that the physician makes. Next slide, please. Now, finally, I want to show you from the same line of research what happens when you put together physician implicit bias and patient suspicion or patient attitudes. What we find is when you have the combination of a physician with high implicit bias and a patient with high levels of suspicion, the patients believe that it will be more difficult for them to complete treatment. Next slide. We find similarly, this time we're talking about mistrust, which is, I think I pointed out to, is separate and unique from suspicion. When we have the combination of high mistrust and high implicit bias, we find that the physicians believe that the patient will not be is going to be much less likely to tolerate this treatment. So we see how implicit race-related attitudes not only affect the behavior of the physician and the behavior and perceptions of the patient, but they interact to produce poorer outcome expectations on the part of both the patients and the physicians. Next slide, please. Now I want to turn to what we know from the perspective of race-related attitudes about pain management. There's been considerably less work on this. The first slide I want to present to you is just a general statement about barriers to pain management. These are reports of cancer survivors. And again, we're looking at odds ratios, okay? So what these cancer survivors are telling us, white, Black, and Hispanic, is that the Black patients and the Hispanic patients are somewhat less likely to say they can tolerate the pain. Remember, these are relative odds ratios. So all you got to remember is likelihoods, okay? So the notion that I believe Dr. Gray referred to, that somehow Blacks are better able to tolerate pain or less likely to feel pain, that's not considered to be a barrier to pain management. And indeed, the opposite seems to be true. Discussing pain with their physicians, Black patients are much more likely than white patients to worry that they might upset the doctor. They're also much more likely, as is true of Hispanic patients, to not be comfortable about their pain. They are also much more likely, as is also true of Hispanic patients, to have a physician who simply did not ask them about pain. And finally, and I think this reflects some of the things Dr. Pace was talking about, when they were prescribed a pain medication, they were much more likely to find that the pharmacies that they use said that they did not provide the medication. So what we see here is racial disparities in pain management between white patients, Black patients, and people who self-identify as Hispanic or Latinx. Next slide, please. Now, I also collected some information about communication and past discrimination, and we find that it affects satisfaction with pain treatment, okay? So these patients actually were not cancer. These were patients being treated for arthritis in the VA system. This slide's a little more difficult to understand, but basically, it's the relative odds of a patient being satisfied with the treatment they received, okay? When their satisfaction with communication was high, they were much more satisfied with their pain treatment than what was low. But with regard to race-related attitudes, if they reported that they'd had high levels of past discrimination, they were much less satisfied with their pain treatment. So again, perhaps relating this to Dr. Gray's talk, their past experiences with racial discrimination affected their level of satisfaction with treatment. Next slide, please. And this final slide, in terms of data slides I want to show you, is a study that was done, I'm sorry, the previous study was with cancer patients. This was done with arthritis, patients with arthritis. Okay. The researchers in this study, first of all, got to measure something called cumulative disadvantage. Cumulative disadvantage refers to the physical and social circumstances that might put a person at disadvantage. This might be living in a high poverty neighborhood. It might be being a member of a group that has been the target, who has been disadvantaged in our social structure and things like that. That was the first measure they got. The second measure was asking these patients how much past discrimination had they experienced. And then the final measure was asking them to report their pain. And what they found in this study is both cumulative social disadvantage and past perceived discrimination affected how much pain these patients reported. So placing reported pain in a social context, and to a certain extent, or to more than a certain extent, in the problem of racism in America, shows us that these factors affect reported pain. I should mention that there's a very high correlation in America between cumulative disadvantage and race, with people of color experience much higher levels of cumulative disadvantage. Next slide, please. So in summary, racial health care disparities are a likely cause of racial disparity in cancer outcomes. Race-related explicit and implicit thoughts and feelings of providers and patients almost certainly play subtle but important roles in the effectiveness of healthcare interactions. The data there are fewer studies on this, but it's very likely they also play a role in pain management. Racial disparities can be prevented or solved. And addressing pre-existing race-related attitudes is one means to do this. And I think, again, that overlaps with some of the things that Dr. Gray said. But it's extremely important to know that simply addressing implicit bias on the part of healthcare providers will not solve the problem. Any sort of intervention that addresses pre-existing race-related attitudes of either physicians or patients must be done in conjunction with institutions monitoring the effects of these practices and using this to change actual practices. That is, at the level of practical interventions, we have to work at the level of institutions. And it's only by changing the way institutions operate that we're going to be able to reduce healthcare disparities. Last slide, please. And I have a slide that I close all presentations with. Many of you are familiar with this slide. It was, I say 42 years ago. It's longer. I started using this slide a few years ago. But it's a quote from Dr. Martin Luther King in 1966, in which he says, of all the forms of inequality, injustice in healthcare is the most shocking and humane. What Dr. King said, actually 44 years ago, I guess, 45 years ago, is still true today. Thank you.
Thank you very much, Dr. Penner, for just an incredible presentation. There's just so much to take there. And we really appreciate this. We deliberately designed this webinar to be somewhat long because there's just so much to start to unpack here. And before we turn to the panel presentation, I just would like to kick off, and there are a lot of questions coming through. I'm going to try to synthesize several questions and comments that were made in response to this excellent presentation. And they're really around the implementation and translation of this. So how can we begin to help clinicians who hold these aversive racist attitudes to pursue self-reflection, personal insights, make consequential changes in these subtle behavioral features of interactions that you've described? And how can we translate these into interventions that strengthen provider communication, enhance trust, empathy, the feelings of agency and control, all the resultant issues that you've highlighted. How do we begin to translate this into actual interventions? And you say there we have to change the healthcare systems, but can you give just a couple of ideas about what low-hanging fruit for that right now?
I think that you can help physicians in general improve their communication skills. I believe, and I think a lot of people who work in the area of implicit bias think that the emphasis on implicit bias training may well be misplaced, because it's inordinately hard to change implicit bias. And there is no shortcut or quick cure for that. So what I would suggest is what we need to work on is not so much changing implicit bias or explicit bias, but changing the consequences of it. And one way to do that at both the level of the individual physician and at the institution is to provide them with feedback on the consequences of their actions. So, for example, most healthcare now is in very large institutions. If we simply provided feedback to individual physicians about their own decisions, and I'm talking mainly about decisions because these are objective, okay? How many patients did you put on this type of chemo? Go back to some of the disparities that I talked about and some of the pain disparities that Dr. Pace. Just go back and provide them with that information, okay? And at the same level, provide the institution with that. Then you're showing the effects of bias without creating, and this is critical, without creating defensiveness or reactance among individual physicians, okay? And getting the physician to understand the implications of what he or she is doing, okay? And changing the outcomes. So this may be a bit of heresy, but if there was a take-home message, implicit bias is real and it has real effects, okay? But the solution to it may be looking at those effects and feeding that back to the physician, because I think, with minuscule exceptions, that if the physician became aware of differences in how they're treating Black and white patients, what they're saying to Black and white patients, that the physicians would then be much more open to training. They would improve their level of communication to all patients. And they would be much more aware of the things that they're doing, which may work to the disadvantage of the institution. One other thing that's been suggested, I'm blocking his name, is that's what's needed to reduce racial bias in large healthcare systems is to standardize treatment procedures. And I think that is a very important thing. You obviously need to allow physicians some degree of discretion, but it's also true that if you look at procedures for the same problem, for example, surgical procedures for knee surgery, in large institutions, there may be 15 or 20 different ways which vary with the physician who does that. And what's suggested in this solution is that you standardize this, and it's actually been done effectively in a few institutions. I'm sorry that took so long to answer.
That's excellent. Thank you so much. I think in our remaining time, I'm going to invite Dr. Gray and Dr. Pace to join Dr. Panner for our panel Q&A discussion. And again, there's many very rich comments coming in, and we just want to emphasize that this is the first in a series. And so we really hope people will have continuity with this and continue to participate, because we hope that many of the questions you're raising will be also addressed in future presentations. I think maybe I'll first just invite Dr. Gray. You look like you might have wanted to jump in with maybe a follow-up comment on the question I posed to Dr. Penner. So is there anything you'd like to add?
Oh no, Dr. Penner was very thorough with that, and I stand along with him and in his response. I certainly think, and it kind of carries over into one of the questions that came across the panels from Dr. Irby in regards to ways, not only thinking outside of that question with healthcare providers, but thinking about ways that we can improve kind of medical education and research. And I think, certainly the literature has been growing in its understanding of the impact of what's called structural competency, which really delves into kind of incorporating teachings and learnings in regards to social determinants of health and impact of racism on health of folks from diverse backgrounds in our communities. I think also, there's opportunity to actually not only for us to go out into the community more, to get more proximal, and I mentioned that, but also to bring the community in. And so as we think about opportunities in medical education, public health education, bringing community members in, I think about a class that Dr. Electra Paskett and I co-lead, in which we do bring a community member in and to share experiences. In particular, our most recent one in the fall was we brought a Somali woman in with an interpreter, and she kind of shared her experience with breast cancer at a different medical institution and then at our medical institution. I think for students who engage around that, it becomes a very rich learning experience. And two, I think for the community member, it becomes a rich learning experience that they then are able to share with other community members, that they are, again, part of what we do in healthcare and research is to try to build relationships. And certainly there's been a long storied history of fractured relationships that we need to do a better job of trying to repair. And I think too, the other piece was around of that same question from Dr. Irby was around kind of resources and changes. And I think as we think about the research side of it, so I talked about medical education, I think we have to revisit our standards and rigor around doing health disparities research. And I'll drop one article, a really compelling article by Dr. Rhea Boyd and others in regards to that was published in Health Affairs last year. And I'll send that into the chat so people can take a look at that.
Thank you so much. And a question to Dr. Pace and also Dr. Gray. What changes in health policy would, if implemented immediately, make critical improvements in access and reduce some of the structural barriers that impede guideline-based pain management?
So we talked a little bit about the problem of lack of payment, lack of access to the medications in retail pharmacies. We talked a little bit about the language that we use about people who do, actually we didn't really talk about the issues of substance use disorder and how we stigmatize that, how it is comorbid with cancer as much as it is with any other kind of serious illness. And we need to treat people who have substance use disorder along with their cancer as empathically as we would anybody. But we have to look at the words that we use, things like people with substance use disorder rather than an addict. Even calling the words narcotics can be stigmatized. These are opioids. So we have to really think about our words. Dr. Penner talked about implicit and explicit bias. And yeah, you're right, Dr. Penner, I completely forgot about, although how could I with our current political climate, how could I forget about the explicit bias that we see on a regular basis? I want to commend the implicit bias tests that can be taken at through the Harvard website. It's implicit.harvard.edu. I'll put that in the chat box. It's not just about race, it's about even our perceptions about people with body image issues related to obesity, about religion. They're pretty revealing kinds of studies. They may not be perfect, but they're really interesting. I wanted to really quickly to just address a question that was asked in the chat box about how do we ask patients about their concerns about racism? And I'm gonna just admit right up front that I am not an expert in this, that I'm just as uncomfortable as likely anybody is about asking about these concerns. It's almost like talking about sex, right, with a teenager. But I did learn to do that, so we can all learn to ask our patients. And I commend the person who asked about this, looks like Dr. Pandy. And she asks the dignity question in palliative care. I ask something similar. I say, what gives you strength? And you're right, that doesn't usually capture the cultural, racial, and ethnic kinds of concerns. So right now I use the challenges that we see in the media. And I'll say, you know, there's a lot of events in the news right now that really help me as a white woman understand a little bit, or open the door a little bit to some of the problems that people of color face in all parts of their life, but especially healthcare. And I may not be aware, so could you help me understand how are these affecting your access to our treatments? Is it affecting our communication? I just try to open the door and be exquisitely transparent, so that people at least I know I've tried to make the conversation start. Dr. Gray, I would love to hear your thoughts about all of this.
Can I make a quick comment, Doctor? I appreciate what Dr. Pace is saying, and in many respects, I'm in agreement. But I think there's something more basic that needs to be done. In social psychology, which is what I'm trained in, we talk about the best way to reduce prejudice is to individuate the person. So your patient is not a Black woman. Your patient is Mrs. Brown or Mr. Smith, who is married, has 3 children, works, in the case of Detroit, one of the big 3 automakers, and to not treat a patient as a social class, but as an individual. So to me, the first step is individuating the patient, and from then being responsive to the patient's concern. And I'm going to take one other personal privilege here. The thing I neglected to do at the end of my talk was to give credit to my colleagues in the Population Studies and Disparities Research Program at Carmanos Cancer Institute. Everything I talked about was a group effort on the part of my past and present colleagues. And I should have acknowledged them by name, so I apologize to them. Thank you.
And I would just add, to really piggyback upon what Doctors Pace and Penner mentioned, people, in general, they don't necessarily, well, it's been said, I'll say, that people don't care how much you know until they know how much you care. And so that really piggybacks off of what Dr. Penner just said, but also what Dr. Pace was saying, in that as we try to approach these difficult conversations, it starts just from the frame of our relationship to that person. And if we think about, your normal conversation, you gave the example of Dr. Pandy in palliative medicine, asking questions, building relationship. Well, in the course of that relationship, there's opportunity to ask, have you felt respected? Have you felt valued? Have you felt heard? And if answers to such questions are no, then, can probe further. Do you feel as though it was because of who you are as an individual? Do you feel it's because of you as, based on your race? So there are opportunities that present themselves where we can kind of probe a little bit further.
I don't think we could be ending the panel presentation on a better note. There is nothing else to add except for me to turn it over to my colleague, Dr. Rebecca Ferrer, to close out and highlight our next seminar in this series. Dr. Ferrer?
Oh, sorry. I was on mute. Can you hear me now?
Yes.
Okay. Well, sorry. Well, so anyway, thank you. I don't think there's really anything that I need to say to tie it up beyond this, other than that we are having this is the first in the series. Our second, as it says here, has been scheduled for April 9th. And the speakers will be Dr. Nagani, Dr. Setterstrom, and Dr. Marmo. And we hope that you will all consider attending and that we can continue this ongoing dialogue. Thank you to all of the speakers and panelists, and thank you so much to Sandy for facilitating the discussion, and especially to Amanda. This webinar series is her labor of love, and I'm really glad to have been a part of it. So thank you, Amanda, and thank you all.
Thanks, everybody. Have a wonderful rest of your day. And thank you to our webinars. We're so grateful for you sharing your expertise today.
Thank you.
Have a good
Thanks, everyone.